Good morning, everyone. My name is John Groot, and I'm a professor and division chief of neuro-oncology here at UCSF. Welcome to UCSF Neurosurgery Community Grand Rounds. We have three speakers today to present complex cases in neuro-oncology. Just briefly, these are my personal disclosures. And the objectives for today are really to first start by introducing our speakers and then review interesting cases that we think are very educational, one involving thalamic glioma, one recurrent glioblastoma, and one low-grade glioma. And then if there's time at the end, I can provide a brief overview of some of the current neuro-oncology clinical trials. So these are the three contributors today. I introduced myself already. We also have Dr. Brian Toyota, who's Director of Neurosurgery at Regional Medical Center of San Jose and is also Professor of Neurosurgery at UCSF. And Dr. Lauren Borate, she's an Assistant Professor in the Department of Radiation Oncology at UCSF.
Thank you, John. Thank you for the introduction. Good morning, everyone. I'll just jump right into my case. It's a fairly typical presentation for this pathology in this location. Usually it's a combination of motor deficit along with some cognitive changes. This particular case, the cognitive changes predominate, although more typically the motor issues are more evident. And then there's the imaging. It's the daunting image that I think we're familiar with, and even the most seasoned neurosurgeon will look at that scan and shake his head a little bit. Before I get too deep into this particular case, though, I want to step back and just remind ourselves of the context of what we're dealing with, because that really is the umbrella under which decisions are made. So when we step back a little bit and talk about glioblastoma and outcomes, the Stroop paper from the New England Journal of 2005 still is the pinnacle, at least in terms of adjuvant care, and is the basis for which we give counsel to our patients and our families about prognosis and what they can expect. And it's been almost 20 years, which I think is a commentary by itself. But as I said, it really was a game-changing in terms of our attitude and what we do with this cohort of patients. So what this paper did, as you recall, or maybe it's been so long you don't recall, but it compared to radiation alone to temozolomide as well as radiation. So I'm going to start the morning with a softball question and ask the community out there, what is the benefit of the Stroop protocol? I posed it as a 2-year survival for glioblastoma, and I'll give you a minute or so to pick the option. Right, so the 2-year survival, when you add temozolomide, it's a bump up from 10% to almost 27%. So that's a pretty significant figure. And if you're methylated, that can be up to 50%, right? So if you look at it in terms of percentage survival at the 2-year mark, it's fairly impressive. If you look at the median survival benefit, it's 2.5 months, right? Which is a different sort of number to deal with. And as a sidebar, when I'm giving prognosis to family and to the patients, and I guess this advice is more for the residents perhaps, is that I'll always give a 2-year survival mark, right? Because if you use median survival and you say median survival is going to be about 14, 16 months, they take out you know what they do? They take out their phone, they put it on their calendar, and they mark it down as this is the day that my doc said I wouldn't survive past, right? And it's kind of a daunting way to live, but maybe philosophically it's a good way to live, to remember our mortality. But in general, I find it more hopeful and encouraging when you talk about there's a 1 in 4 chance you'll survive to 2 years. Let's all work to get you to be that in that 25% group. And so when I give prognosis, I'll always use percentage at a 2-year sort of mark rather than a median survival. And so that is our, in general, I think the prognosis we give patients with glioblastomas, but we'll unpack that a little bit as we move along in the talk. And so the other part of glioblastoma is when we receive patients in the clinic and you look at their imaging before you even see the patient, probably 9% of the time, you're pretty confident that this is a glioblastoma. And instinctively, even within that group, you have a sense of what patients are going to do better than other patients. And it's not just an instinct, of course, it's based on literature and statistics. But in general, I think we have a good sense of which patients are probably going to fare better. So the next question you can see before you. So I'm letting people warm up with, I think, a pretty straightforward question. All right, so it really is all of the above. I think this is familiar to everyone in the audience, and I kind of break it down into patient factors, right? So younger age and having a methylated tumor, there's not much we can do to control that, at least not yet. But then in terms of modifiable factors, for which we have an onus, the extent of resection and performance status are pretty important. And these really kind of, in some ways, drive this case. And so probably those in the audience who are caffeinated are going to say, wait a minute, I'm not so sure KPS is a modifiable factor. But as you'll see, it actually is quite important and is definitely something we impact, especially as surgeons. And so finally, let's go back to this case. You saw the brief history, you saw the imaging. And so what do we do with this patient? So this is a very strong audience advocating for surgical intervention. And so like most surgical questions, there's no wrong answer. For this particular patient, and I think this tumor location remains a daunting surgical challenge. You can look at a variety of even recent case series, meta-analysis, and the direct surgical approach has a high likelihood of morbidity, which decreases KPS, which we talked about as a significant prognostic variable, and a reasonably low likelihood of gross total resection. So if you combine both of those, you're diminishing an already poor prognosis. And we know through reams of literature that as one of the factors dictating prognosis, a KPS score of less than 70 significantly diminishes survival and in a related way decreases their tolerance to adjuvant therapy. And so one of the significant markers of someone not doing well is that they can't finish the adjuvant therapy. So again, that's where surgery plays a significant role. There was a recent paper that looked at KPS comparing it pre-op to post-op. And it's not hard to imagine that it really is the post-op KPS that dictates prognosis more so than, than the pre-op. And that's, again, not hard to imagine. So if we take a patient, and there's a significant number that will improve their performance status. So they come in as a 70 and we make them 80 or 90, they're going to do better. There are also the cohort of patients that we make worse. And so the same thing carries in the opposite. So they might come in as 80, but if we hurt them through our surgery and they drop down to 60, we've impacted their ability to tolerate adjuvant treatment, and we've significantly impacted their prognosis by making them worse. And that's why performance status actually is a modifiable factor and something that I think it's important for a surgeon managing a malignant tumor whose prognosis is less than 2 years in general to be very mindful of. And for me, at least in my experience, this is at the forefront considering a deep thalamic glioblastoma. So for this particular patient, it was biopsy only. The result was a glioblastoma, as you might expect, and it was methylated. And so I want to again backtrack and unpack a little bit about the Stoop protocol. And so the next question is, who really does benefit from Stoop in terms of surgical engagement? And so the question is, for those 2-year results that we talked about previously, is that for tumors that have been resected, or is that for all comers? The clue was given, I think, in some of the previous questions in terms of outcomes. Your outcome is going to be better, as this audience well knows, and an important variable is extent of resection. So in fact, if you look at the Stoop, the original Stoop paper, biopsy patients did not benefit. I think there was a statistical trend, but in terms of hardcore statistics, if you had a biopsy only, your response to Stoop, so the combination of chemo and radiation, did not meet statistical significance. And even the current studies looking at biopsy-only patients, their survival is in the realm of 8 to 9 months. So if we're going to use Stoop as our landmark, we're going to use that paper as our basis for giving prognosis. The truth is, without a resection, Stoop isn't technically going to help you. Only if you have a resection will you derive benefit. So I'm going to sort of finish up this talk looking forward about how we can change the biopsy only into the resection equivalent. The next question is to think a little bit, and if you accept that the direct approach has a high chance of morbidity, a smaller chance of gross total, what are alternatives to that? Right, so those are very interesting results. There was some groups which have advocated a very aggressive use of stereotactic radiosurgery in the sense of kind of a supramarginal resection attitude. So they weren't just giving conventional 2-centimeter margins, but they're aggressively chasing all the flare changes with the radiosurgery. And I think with variable results, which were hard to replicate. As you may know, focused high-frequency ultrasound was initially touted as an ablative procedure, but I think for some technical difficulties, it's kind of pivoted to more breaking down the blood-brain barrier and less as an ablative approach. And I think we'll hear about that towards the end of this hour. Gamma tiles are breaking back into the brachytherapy world, and I think are evolving. I don't know if how much of the audience are familiar with the brain path NICO. So it's really operating through a speculum with a guillotine-like device, which can be useful in deep lesions. And I've certainly used that approach earlier in my career for this. And then finally, in a technology with which I have some expertise with this particular technology and these particular patients is LIT. And so I'm just going to end up my talk talking a little bit about LIT and its potential to manage these patients. And so LIT is really a marriage of two technologies. Thermal ablation of tissue using laser has been around for decades. It's been around longer than most of the residents in the audience. And so it's been available. It's been on the shelf for use, but it hasn't really been used because there's really no good way to manage, to control the amount of burn you get from the laser. And so the real innovation that put it back in the forefront was the ability for real-time MR thermography to actually watch what you're doing with the laser. And so here's a schematic. You make a 3.3 millimeter opening in the skull. You use neuronavigation to get into the epicenter of the tumor. In the MR suite, looking at the monitor, you turn on the laser and you watch it ablate the tumor. And once you're satisfied with the extent of ablation, you can rotate the laser, you can adjust it to catch the different poles of the tumor. And so you essentially are bringing the tumor temperature to 42 degrees Celsius for 10 minutes will kill any cell in its path. And once you're satisfied with the extent of thermal ablation, you adjust the probe. Right. And so, as I said, the real innovation was the ability to watch the temperature of the brain as you're doing the procedure. So here's a real-time screenshot showing the temperature of the brain, and then the laser is being turned on, which you see as those red lines represents the probe, and you see the temperature change. The tumor's been outlined. When you see the edge of the tumor hit 42 degrees at 10 minutes, you know you've done your job. You turn off the laser and you adjust it. So this ability to watch what the laser is doing gives you the ability to control the extent of ablation. And so I'll just flash through a few examples. A 66-year-old with a fairly large basal ganglia thalamic presenting with a moderate hemiparesis, and then a 3-week post-laser treatment. One of the things you learn in laser is that your post-op scan looks very similar to your pre-op scan, except now it's all a hub of necrosis with a rim of enhancement. Here's a more typical small thalamic lesion presenting early, as they often do with a hemiparesis. There's an actual screenshot from her laser treatment. You can see the laser coming in from above and a 3-week post-op scan. So again, you can imagine, although it hasn't been resected, that nest of glioblastoma has been ablated. A more daunting case of a 24-year-old with a recurrent tumor, which was glioblastoma. And so we staged this, and after stage 1 got this kind of ablation. And so I can end my part of the talk by describing LIT as a minimally invasive and very patient-friendly strategy to turn the biopsy-only patient into a virtual resection. Granted, it isn't literally resected, but the neoplastic cells are ablated. And it really is a technology available virtually to any hospital with very little infrastructure and a modest amount of training. So I'll end my talk by saying that they remain surgical challenges. It certainly could be an entire session on the direct approach to thalamic malignancies. But in general, and certainly in the community, this cohort of patients are relegated to biopsy only. And I think the future is the development of minimally invasive strategies to convert these biopsy-only patients into an aggressive cytoreduction procedure.
Okay, well, then we can move on to Dr. Borate and case number 2.
Good morning, Dr. Borate from Radiation Oncology. Lauren, I treat CNS tumors and I lead our palliative radiation program. I'll be going through a quick recurrent glioblastoma case this morning. So this is a 39-year-old man. He presents with 2 months of alexia without agraphia, and then 5 days of severe headache, blurry vision, and he had an MRI that showed this large left-sided necrotic mass consistent with a high-grade glioma. He underwent resection and had a gross total resection. Pathology came back as grade 4 glioblastoma with a CDKN2AB deletion, IDH wild type, EGFR amplification, MGMT promoter methylated. He completed adjuvant chemoradiation and had 7 cycles of temozolomide. This was his initial post-chemoradiation scan, so about 1 month after finishing chemoradiation, which in his case, fortunately looked pristine, but in many cases, we don't see this. We see increased enhancement concerning for pseudoprogression. So I thought we'd talk briefly about this in the introduction to this. So 10 to 30% of patients treated with chemoradiation develop pseudoprogression, which is characterized by increased enhancement or enlarged size of the treated area. It correlates with high rates, it has high rates in patients with methylated MGMT promoters, and is associated with prolonged overall survival. Distinguishing treatment-induced changes from progressive disease has important implications to avoid premature discontinuation of a treatment regimen, and I know many of us in the audience have struggled with this in our patients. The RANO criteria state that within 12 weeks of chemoradiation, if there's contrast enhancement outside the radiation field or biopsy-proven viable tumor within the radiation field, that's progressive disease. So increased contrast enhancement within the radiation field within the first 3 months is pseudoprogression. And after 12 weeks, the same as above, or increasing size of the original lesion. MRI sequences beyond T1, T2 flare can be helpful in determining pseudoprogression beyond versus tumor progression. We're often looking at perfusion, spectroscopy, and PET agents to help us make these decisions. And Dr. Young, who might be in the audience at Parnassus, recently published this great schematic depicting a decision algorithm for patients with imaging findings concerning for pseudoprogression versus tumor progression. And just a quick word on pseudoprogression versus radiation necrosis. The main difference is time. Radiation necrosis tends to be a delayed effect. Pseudoprogression happens early on. and improves over time. Whereas radiation necrosis, there's often need to intervene if symptomatic. And similar to pseudoprogression, biopsy or MRI can be utilized to distinguish the two. Okay, so back to the case. This was his MRI after 7 cycles of temozolomide. He had this local recurrence within the resection cavity. He's a dancer. He's completely asymptomatic, KPS of 90 to 100. This was to be a first poll question. How would you manage this recurrence? Good, right audience. John or Brian, any thoughts? I mean, this comes up in tumor board all the time.
Yeah, definitely in this audience, he's going to go back to the operating room. And I think the attitude will be prevailing. You're going to aim for a supramaximal resection as allowable. Obviously, his optic radiations are endangered by an aggressive resection. I'm assuming his visual fields are intact still, perhaps remarkably. But at this point, with his recurrence and such a bad prognosis, an aggressive surgical approach would remain the first option.
And then the other opportunity is there are also sometimes some surgical clinical trials where patients receive treatment prior to surgery. So you could also integrate being on a trial as well as that surgical option.
Thank you. This patient, oops. So just as an overview for recurrent glioblastoma, there is no standard treatment paradigm. To echo what Brian had said earlier, there's kind of no wrong answer, and it really depends on the patient factor. Age, KPS, and location of recurrence are especially prognostic. Ependymal involvement portends a particularly poor prognosis. Survival overall is about 6 to 12 months after initial recurrence, but with wide variability. These most commonly recur at the initial site of disease within the high dose of radiation, and there's some data to suggest that recurrences out of field actually have a kind of divergent evolution and might have differing mutational status on biopsy. So this patient underwent an aggressive surgical resection, as you all correctly predicted, and enrolled on a precision medicine trial with afatinib and abemaciclib to target his specific mutations. Poll question number 2, does extent of resection at recurrence impact survival? Okay, good mixture here. So before moving on, Brian, what do you think about extent of resection and survival in the recurrent setting?
Again, I guess from the biologic attitude, it would portend to be the same as on initial presentation, and there's no reason to think it wouldn't have the same benefit. Obviously, the patients are a little bit more fragile, and so I can go back to my talk about the impact of aggressive resection on performance status, and certainly my mantra is that you really can't hurt a patient with a glioblastoma or a malignancy in the brain, because it really is going to impact negatively on their outcomes, despite how satisfying the post-op scan might be. So I think I'm not clear there's literature out there to support it, but the first impulse certainly would be that this is going to help them.
So there are several retrospective series showing that improvement of survival and progression-free survival with a greater extent of resection at the time of recurrence, but I would say that those findings are probably heavily biased by patient selection, exactly as you said. The position statement of the Congress of Neurologic Surgeons is that repeat cytoreductive surgery is recommended to improve overall survival based on level 2 evidence. He then unfortunately had a second recurrence about 4 months after re-resection. He was symptomatic with visual field deficit, alexia, and aphasia, presented at our tumor board. This is a much larger recurrence now, you can see, and it's along the ependymal margin, much bigger than his prior recurrence. And the recommendation was for reirradiation, hypofractionated 35 gray and 10 fractions with bevacizumab. So when we consider reirradiation as modality for glioblastoma, we kind of think through our own decision tree. What is the fractionation, or how long are we going to continue the treatment? Conventional, we really only reserve for patients who have had an out-of-field recurrence and have an excellent KPS. Hypofractionated is our most standard, something like 35 gray and 10 fractions. Radiosurgery, gamma knife, or other types of radiosurgery, and brachytherapy. Patient selection, again, age, KPS, what are their symptoms, the location of recurrence, if it's in or outer field, size of recurrence, time from prior radiation, and what's the goal? Is this life prolonging, or are we just palliating symptoms? There was a recent publication updating the results of RTG 1205, which was a trial comparing Avastin alone versus Avastin plus hypofractionated radiation in the recurrent setting. Patients could get kind of any flavor of radiation, protons, photons. And the results showed no difference in overall survival, so about 9 to 10 months in both groups, but an improvement in progression-free survival in patients that received radiation and Avastin. What we worry about most is symptomatic radiation necrosis. It happens commonly in the upfront setting, and the incidence is even higher in the re-irradiation setting. It's dose, field size, and modality dependent. And there's a lower risk with longer interval from the initial treatment. And we've learned from RTG 1205 and other studies that concurrent Avastin decreases the rates of grade 3 or symptomatic radiation necrosis. What has not been well characterized, and something that we need to spend more time learning about, is what is the symptomatic or quality of life benefit from re-radiation. I would say anecdotally, many patients have improvement of symptoms following re-irradiation, but there are really no studies looking at quality of life or patient-reported outcomes in this setting. And finally, unfortunately, this patient had a third recurrence 8 months after his second radiation, sudden onset vision loss with hypothalamic and optic nerve involvement, kind of dissemination in the CSF. He received 5 palliative radiation to his optic nerves to try to preserve the small amount of vision he had left with Avastin, and a few months after this, transition to hospice. That is all I had. I want to make sure we have time for John.
Thank you. That's great. All right, so I'm going to present a low-grade glioma case. I don't have as many poll questions. I think I only have 2, but I'll go ahead and get started. This is a case of a 34-year-old woman, no significant past medical history, who is being evaluated for incidental issues and had an MRI scan performed that showed an incidental finding. The imaging was concerning for tumor, and I'll show you what that looks like here. So you can see this right frontal non-enhancing hyperintense lesion, and on the T1 post-GAD, you don't see any contrast enhancement. So what was done, the patient was seen by neurosurgery, and a right frontal craniotomy was performed with tumor resection using a sleep motor mapping. This is the postoperative MRI, basically showing a gross total resection of the non-enhancing tumor with some immediate postoperative changes, as you would expect. So what is the appropriate approach for managing an incidental low-grade glioma? There have been many studies on this, and I just picked one to present here. Dr. Berger obviously has been the leader in this field and wrote the book, so to speak, on management of these patients. And in this multi-center retrospective study, looking from, I think, patients in France, Italy, Canada, and the United States, that clearly the pre-operative tumor volume, the lower the volume, the longer the survival. And then, of course, as we all know, a greater extent of resection improves outcome quite significantly. And these are, not even getting to the median after a time period of 12 years. So a really huge impact on survival. And I was just going to ask Dr. Toyota if he wouldn't mind commenting on sort of how you think about an incidental finding, a patient who doesn't have symptoms from the tumor, but do you watch it for some period of time before you move to resection, or how do you think about that?
I think for a while there was a lot of equipoise, and I think certainly earlier in my career, wait, watch, and see was the first instinct for an incidental lesion in the sense of first do no harm. But as the data you presented has become more prevalent and convincing, I think we are able to advise patients that despite the fact that it's incidental, you're neurologically intact, it's a serendipity that this was discovered, and in terms of your prognosis, the best thing is for us to intervene. And so that's obviously an easier argument for a patient when you have data. Before that, it was very difficult to convince someone with an incidental lesion that brain surgery was the right way to go. So I think now, because we have data, we're much more aggressive with an incidental lesion.
Thank you. Okay, so the diagnosis was IDH mutant astrocytoma, CNS WHO grade 2. It was IDH1 PR132H mutant by IHC, HRX loss on IHC, and the UC500 was pending. So I wanted to sort of ask the question here, what are the most important factors when deciding whether to treat a newly diagnosed surgically resected IDH mutant WHO grade 2 glioma? Great. So I think we'll kind of address some of these things here as we move forward, but generally we think about all of these factors as being kind of critically important in terms of whether or not to actually treat or to watch. So generally speaking, this is sort of going back, up 20, 30 years. There's been sort of two main approaches that we take to treating newly diagnosed low-grade gliomas. A lot of this data is sort of retrospective, which we'll review, but both for oligodendroglioma and astrocytoma, there is a period of observation in some patients that we feel observation is appropriate. And I think those factors have been sort of reviewed over many, many years. There's a Pagnotti criteria, there's the RTOG 9802 criteria, but observation is one option. Or what was generally the case, I think previously, was patients were deferred to radiation, followed by PCV for oligodendroglioma, or radiation followed by TMZ for astrocytoma. So the goals of the treatment are obviously to slow tumor progression, increase survival, reduce toxicity and symptoms associated with tumor progression. So we think a lot, for a patient maybe who has a lesion right next to the motor strip, and then also, potentially to delay or prevent transformation to a more aggressive grade of tumor. So in historical context, I think some of the best prospective data that we have is from RTOG 9802 and 98, started in 1998. And these patients with newly diagnosed low-grade glioma were randomized, and again, based on the sort of risk criteria that were being used at the time, low risk being age less than 40 and a gross total resection. Those patients were observed. For high risk, and that was also defined as age greater than or equal to 40 or subtotally resected. And those patients were then randomized to radiation or radiation followed by up to 6 cycles of PCV. So the overall survival for all patients on the study in the high-risk group demonstrated a very significant improvement in median overall survival of 13 years for the combination compared to 7.8 years for those patients that just received radiation. And then if you look specifically, Jan Buckner went back and were able to pull out those with grade 2 oligo versus grade 2 astrocytoma. And the oligodendroglioma patients had probably the largest benefit in terms of median overall survival in the combination group, RT followed by PCV. What was interesting is that there was a separation of the curves for astrocytoma, but this did not actually meet statistical significance, which may have been just because of the small number of patients that were in that particular study. But we also know that these treatments actually certainly have a lot of potential toxicity. Dr. Borate talked about radiation necrosis. Over time, you can see vasculopathies, patients having spontaneous hemorrhages, stroke, particularly in some of those longer-term survivors. Treating patients with temozolomide can induce hypermutation. And of course, you know, the treatments that we have can certainly cause neurocognitive impairment. And I think importantly, if you think about patients who are living with this disease for, you know, not just a couple of years like with glioblastoma, but maybe even decades, the health-related quality of life really declines quite significantly, both cognitive, emotional, social functioning role in life, and fatigue and insomnia progress, you know, over 12-month intervals for over a decade in this particular study. So a huge impact on patient quality of life. So fortunately, we now have a new therapy that might allow us to delay radiation and chemotherapy treatment. So this, I'll just sort of jump into the study design. This is the INDIGO trial investigating vorasidenib in glioma. This was a randomized phase 3 trial comparing vorasidenib once daily to placebo. This was for patients with IDH 1 or 2 mutated oligodendroglioma or astrocytoma. They could have only had surgery, and surgery had to be within 1 to 5 years of starting on the treatment. They had to have measurable non-enhancing disease. And then it's a select group of patients because those were not deemed to be in immediate need of radiation or chemotherapy. So that's, I think, going to be an important factor in terms of how we review these results. So the primary endpoint was met, hazard ratio 0.39. This had, I think, 9 zeros in the p-value, so highly significant delay in progression-free survival for those patients treated with vorasidenib compared to placebo. Really incredible results for primary endpoint. If you look at the subgroups in the forest plot, I think there's some really interesting features here. You know, it looks like you know, patients who actually were older achieved as much or maybe slightly more of a benefit to this therapy, which again, when we think about age as a negative prognostic factor, this is a very interesting finding. It is interesting. It's not clear why Western Europe, their patients were overlapped with 1 in the hazard ratio and did not have quite as big a benefit. I don't know if there's a difference in the way patients are treated there. It didn't matter where the tumor was located. So one question we always ask is, you know, does it matter if you wait, you know, 2 years or 5 years before you start on this drug? And it looks like those who had surgery and started on treatment less than 2 years had very similar benefit to the therapy compared to those who didn't get started until after 4 years from their last surgery. And both co-deleted and non-co-deleted patients had benefit from the therapy. And then the last point down at the very bottom, I think this is very interesting. Those patients who had the longest tumor diameter of greater than 2 centimeters at baseline tended to have a greater benefit, whereas those that were smaller had less of a benefit. And you know, it's interesting. We'll see what the results show at SNO this year when they start looking more at response rates. But I think, you know, this could be that these very small tumors are actually not progressing very rapidly, and again makes one think that you might be able to watch some of these patients. The second kind of co-primary endpoint was time to next intervention, and this is broken up by co-deletion status. So again, the patients that were with oligodendroglioma on the left tended to have the greatest benefit on this therapy, where there really was no very, very little progression for patients with oligogenic glioma. Okay, so next polling question. So all patients with newly diagnosed IDH mutant WHO grade 2 glioma should be treated with vorasidenib. All right, we had 7 respondents, but a couple people said yes automatically. Depends on tumor molecular profile, and then some who are still undecided. I'm in the undecided group as well. So I think one of the important things to remember is that this drug was tested in grade 2 tumors. And so I think we will learn a lot more in actually also at SNO. I think there'll be some molecular data that's being presented to know whether or not tumors that might have, for example, CDK and 2A/B co-deletion, which would make them a grade 4, whether or not those patients were actually included in the study, or whether or not they were would actually benefit from this. The data from a phase 1 study showed that tumors that were enhancing did not have as big of a benefit to this therapy. That was a phase 1 study. I think there were 30 patients in the arm that had enhancing tumors and treated with vorasidenib. There were 0 patients who responded in those 30 patients, and the time to progression was, I think, about 2.5 or 3 months. So much less benefit in the enhancing tumor group, but more to learn in that regard. So in summary, newly diagnosed IDH mutant low-grade glioma remains incurable. Current standards of care are effective, but may lead to long-term toxicities. Vorasidenib met both of its primary endpoints in delaying PFS and time to next intervention. I think there's still uncertainty as to whether or not IDH inhibition actually changes overall survival. It's going to be quite some time until we learn that. We hope that this therapy could be almost disease modifying, but I think we'll have to wait to understand that impact on OS. I think the optimal timing of definitive radiation and chemotherapy in the context of upfront IDH inhibition is still largely unknown. I think when we look back at the RTOG 9802, those patients are very different than the patients who were in the vorasidenib trial. For example, patients that in 9802 had surgery and then were immediately randomized to radiation or radiation plus BCV. So there wasn't any watch and wait in that group. So this is a totally different group, and it's difficult to compare those two. And then we really need to study, I think, the best way to use these IDH inhibitors in patients with enhancing and or grade 3/4 IDH mutant glioma, where I think there's a lot of creative ideas out there of using combinations of these drugs together with more standard approaches, including radiation and chemotherapy. So with that, I think we can take some questions, maybe for all 3 groups. And you can certainly put questions in the chat box, or can be asked live, I think, at Parnassus.
John, I have a question. What's the mechanism of action of vorasidenib?
So it's an IDH1 and 2 inhibitor. So it's actually blocking. So IDH1 inhibition, leads to sort of overactivation and greater shuttling of alpha-ketoglutarate to 2-HG, and so 2-HG is the kind of oncometabolite, and so blocking IDH then dramatically diminishes the 2-HG content within tumor. So effectively kind of shutting down the overactivation of that pathway. So Jenny Taylor has a question for Dr. Toyota. What are your thoughts about neoadjuvant role of IDH inhibition before surgery?
Yeah, I think it's in our oncology world, it's certainly different than the rest, where that's a very commonplace neoadjuvant approach to neoplasm, and still unexplored, I think, in a definitive way for our group. So I guess my simple answer is that it's not yet commonplace. And a lot of it's because the patients present with mass, and our first order of business is to remove that mass effect, improve their KPS, as I discussed, their quality of life, and their tolerance for adjuvant treatments. So unlike other organ states where that's less of a factor for us, that's very important. And so that's why I think in general, it tends to be a less common approach. But certainly in the low grades and obviously in incidental lesions, that portends a greater opportunity to explore that potential.
Thank you. That's great. Oh, hi, JC.
I have a question actually for both you and Lauren regarding what your thoughts are right now about what we should be doing with a grade 2 tumor that has had what we think is a gross total resection, timing of either vorasidenib or more definitive chemoradiation.
Great question. I wish I knew the answer. My personal feeling is that if it's a patient who has had a gross total resection of their lesion, that we can observe them, and my preference would be my thought process is to observe them until I have some indication that there might be some tumor growth, at which time I would probably then start the IDH inhibitor.
Yeah, I think it's a tough question to answer with the data that we have now, but after a gross total resection, I don't think you'd find many of us advocating for radiation immediately for a grade 2 tumor, particularly not a grade 2 oligo. And you know, the high kind of classical higher risk groups, subtotal resection, older age, neurologic symptoms, that's maybe a slightly different question. And you know, back to John, I don't know if in those patients you would jump to radiation and PCV right away, or you'd start with the IDH inhibitor.
Yeah, again, if it's truly a grade 2 and there's no molecular features that are concerning for a higher grade, I think I would still continue to observe it. And again, I think your comment about oligodendroglioma is spot on, because I think with an astrocytoma, we might be a little bit more concerned, particularly in an older patient, and might decide to treat them with IDH inhibitor earlier, but you have a low threshold to move to radiation if there was any changes.
I think in that setting also, it's hard to sort of quantify this or scientifically define this, but for me, part of the question is, if the tumor is slowly growing, kind of where is that growth and what direction is it heading? And I'm much more uncomfortable with tumors that look like they're heading into the corpus callosum, or looking like they're wanting to spread into other parts of the brain, as opposed to fairly localized growth, where I feel like we have a little bit more time to be creative in our treatment thought processes. But I'm not sure that that's something that we're ever going to be able to actually test in a trial.
Yeah, great point, JC.
I think with that, we can go ahead and close it up. And thank you, everybody, for joining.
Thank you.